open the panel discussions again. May I invite our next speaker, Dr. Mayur Moreker, Childhood Uveitis, 5 Differences to Remember.
Good morning, everyone, and thanks for having me here. We have a rheumatologist in the audience, so this is going to be interesting. These are my teachers, and I always start with acknowledgements to them. And you'll notice here that the co-authors include a pediatrician, a pediatric ophthalmologist, and a pediatric rheumatologist. Coming to the introduction, childhood uveitis is a unique but common situation faced by a pediatric ophthalmologist and a uveitis specialist. It is unique because it involves certain important differences from uveitis in adulthood. So this is how generally childhood uveitis would present. That is the left eye of a 7-year-old girl with non-granulomatous anterior uveitis and band-shaped keratopathy with a mature cataract. You see there is no redness, it's a white eye. So coming to the first difference in presentation, in adults, uveitis is often accompanied with redness, pain, and watering and decrease of vision. But childhood uveitis, especially in GIA, is known to be silent, that is in a white eye, anterior and characterized by band-shaped keratopathy, posterior synechiae, and complicated cataracts. However, there is this other entity that is juvenile spondyloarthritis, and children with juvenile spondyloarthritis are found to have symptomatic anterior uveitis, with many patients having redness, pain, and light sensitivity. So a slide or two on what is spondyloarthritis. We know it's a group of inflammatory arthritis affecting both children and adults, and it is characterized by the presence of enthesitis, a potential involvement of the spine and sacroiliac joint, a strong association with HLA-B27, and development of uveitis, which is more often acute onset and or symptomatic. But what's there over here is that the International League of Association of Rheumatology, that is ILAR, classification of JIA does not recognize a specific entity for juvenile SPA patients. So juvenile SPA patients are considered as a part of JIA. Juvenile SPA includes these 5 entities, that is enthesitis-related arthritis, juvenile psoriatic arthritis, undifferentiated arthritis, reactive arthritis, and the arthropathies associated with inflammatory bowel disease. Juvenile spondyloarthropathy-related arthritis can be difficult, like we encountered in this 13-year-old boy who was HLA-B27 positive, a very severe non-granulomatous pan-uveitis. You can see there that we've used a lot of immunomodulation, including infliximab, adalimumab. A lot of challenges, especially when we were doing cataract surgery, we required iris hooks. There was a fibrinous anterior capsule. There was cyclitic membrane. The eye was almost pre-thysical, and we had to use the IOL on the sulcus. The surgery is done by a vitreoretinal surgeon using a posterior approach. Final best corrected visual acuity achieved here was finger counting 1 to 2 meters, and that's thanks to a rheumatologist who did a lot of immunomodulation for this patient. So coming to what are the gender and age characteristics of JSPA. JSPA is something that really entices me. Now herein there are 2 groups. The first group that conventionally presents in patients less than 4 to 5 years of age, and it is the one that's similar to oligoarticular or polyarticular GIA. It has a female preponderance, there is dactylitis, and there is a high incidence of ANA positivity and uveitis. And the second group that presents at a later stage, the predominant population is boys, and they have enthesitis, sacroiliitis, and psoriasis. So to say that in JSPA we have 2 groups, the first group which is the silent group, that is like JIA, and the other group which is like the adult group. Now the difference too, that is in relation to DMARDs. So in adult uveitis, initial attacks may be treated with topical or oral steroids with the possibility of a watchful expectancy and a calculated delay in the introduction of the DMARDs. But in childhood uveitis, especially those related to JIA, one should have an early introduction of DMARDs, with the drug of choices being methotrexate and adalimumab, as was discussed some time back. There are other agents also that are useful. But in pediatric uveitis, probably the two most important points are the zero tolerance issues. The zero tolerance issues involve zero tolerance towards inflammation, and even if the relapses are limited to the anterior segment, they mandate increase in immunomodulation. The other zero tolerance issue is for the requirement of oral steroids. One should see to it that DMARDs are at a level which is enough so that one is able to stop the oral steroids in pediatric uveitis. Now, treatment recommendation is there with DMARDs. They are associated with a reduced risk of developing uveitis, and corticosteroid intake in JSPA actually decreases the odds of developing uveitis. Among the conventional DMARDs, the methotrexate and sulfasalazine have been known to reduce the risk of uveitis onset. Of course, this data is a little older data. Now we have adalimumab. The fourth difference probably is with the use of NSAIDs. We use a lot of NSAIDs in adult uveitis. NSAIDs in JSPA do not decrease, but rather they increase the risk of developing uveitis. And this is an important fact because many patients with ERA who may present to a pediatrician, and the pediatrician may start NSAIDs. So NSAIDs in juvenile spondyloarthropathy are completely no-no. They actually increase the risk of developing uveitis, and therefore there is a requirement for consideration of the strategy among all treating clinicians. So what are the treatment recommendations for JSPA regarding biologics? It is this agent, etanercept, which given as monotherapy or in combination with methotrexate actually decreases the risk for uveitis manifestation. However, patient groups which have received these medications is very small. We have used this in a few patients in our practice and found it to be a very useful agent. The fifth difference comes to screening and follow-up. When it comes to screening or follow-up, the essential difference in patients with JIA or established childhood uveitis in JIA is the need for a very close follow-up, a 3 to 4 monthly follow-ups, even if the eye is silent and insidious. This is obvious because the eye is silent, the patient is not going to come forth with complaints of redness, pain, decrease of vision. Regarding screening and follow-up, there are three things that one should keep in mind. Children with JSPA, we think they are symptomatic with acute anterior uveitis, and they would present with pain, light sensitivity, and redness of eyes. Having said that, that would be the subtype where HLA-B27 positivity is about 38%, and the ERA group has the highest rate of HLA-B27 positivity. So it is this ERA patients who would actually present with the redness, pain, decrease of vision. But the early onset JSPA, which is similar to oligoarthritic JIA, are the ones that present in a silent eye and therefore require a closer follow-up. So ophthalmology screening should occur every 3 months for children with JSPA and undifferentiated arthritis who are ANA positive and less than 7 years of age. Patients who are the older age group, they can be kept on a yearly follow-up. There are various screening protocols, the German protocol which recommends yearly examinations, the British guidelines which recommend a 3 to 4 monthly examination. In India, since ERA is the predominant population, we could have yearly examinations, but in the early onset we should have a closer follow-up. With this, I would like to end the presentation and would be open to take any questions. Thank you.
Are there any questions? Yeah.
I'd like to just highlight few points regarding the epidemiology. Firstly, like if you see the Western literature, oligoarticular GIA is the first common cause, and then polyarticular GIA is the most common cause. But in India, ERA is the most common cause of GIA. So, but the ERA that we see don't present with much of chronic anterior uveitis. As they grow older, maybe one or few cases may be there, but as they grow older. But in India, it's mostly the polyarticular GIA and the juvenile PSA, which presents mostly with uveitis. And in the adult phase, they come with acute anterior uveitis. That is number one. Second, you mentioned about steroids. So this, you mean oral steroids are contraindicated in, increases the risk of uveitis, or is the topic, NSAIDs? You mean to say
Oral NSAIDs.
Oral
NSAIDs.
But we,
So
we use a lot of oral, but we don't see, from a rheumatologist perspective, we don't see that much of uveitis in ERA patients.
So what I meant was that when these children have uveitis, the ophthalmologist should not resort to oral NSAIDs for treatment of these uveitis. So when these children will have uveitis, it is better to resort to DMARDs.
Yeah. But we, anyway, from the rheumatology side, we will be increasing. So that can also cause increase in risk of uveitis then?
No. That wouldn't be. That
Okay.
wouldn't be.
And the third thing is regarding the use of biologics. So we don't use etanercept much for uveitis. It's adalimumab, infliximab or
Yes.
golimumab. Rather, etanercept is, we say, contraindicated in uveitis.
Yeah. So that is something that we have been talking with our pediatric rheumatologists. We have had a patient or two where the uveitis and the knee joint pain wasn't getting controlled even with adalimumab, in which we've added etanercept and we found a good response. So per se, that drug seems to be the one which may be the rescue drug when you have already used methotrexate and adalimumab and still not getting response.
But there are other agents like infliximab or golimumab. So of the agents, we would first switch to the other, like infliximab or golimumab before. If you ask a rheumatologist, mostly etanercept is the last one. But there are cases where we have used etanercept or even secukinumab in the acute uveitis along with methotrexate.
Yeah. In fact, we've even among the new drugs, we've even tried tofacitinib in children, and even that gives a good response if used as an added agent to methotrexate.
We have been using a lot of tofacitinib even without methotrexate and I think Dr. Ramana's baricitinib trial will be coming very soon.
Yeah.
Within the next 6 months, the baricitinib trial will come.
Thank you.
Thank you so much, Dr. Mayur.